Great. Thank you very much, Angela. And it's wonderful to be here today talking to you folks. I'm sorry that I haven't met our new first year students yet. I wasn't able to attend the festivities in the first week of class, but I hope we'll get to know each other soon. So today I want to talk to you about this 2021 heat dome and what I really refer to as a mass casualty event, and I hope you'll understand why as we work through the presentation here. But before I start, I want to go back to this idea that I've been associated with the OEH program since 2001, and that's absolutely true. And I know we're celebrating the anniversary of the program this year, and I just want to give you a little bit of history of how I got to be where I am right now. My background is in environmental engineering, and when I was doing my undergraduate studies, I fully intended to direct my career towards international development, and I have worked internationally quite a bit. I came back from some time doing some engineering work in Uganda, and I came back without a lot of money because international development doesn't pay very well. And I needed a job to hold me over while I figured out what my next steps were going to be. And I contacted a professor friend at UBC who set me up with another professor friend, and together we read through the job ads at UBC, and every job ad we read through together, he said, "Could you do that?" And I said either yes or no. And one ad that we came across was to do some data analysis for a risk assessment of the sulfuric emissions from the Chevron refinery, or what was then the Chevron refinery in Burnaby. And we read the job description. I said, yeah, I could absolutely do that. I have the skills for that. And he said, well, you should apply. It's a 6-month contract. That'll fill in the gaps while you're figuring out what's next. And so I applied for that job, and I was hired by Susan Kennedy to do that work, and co-supervised by Ray Copes, for those of you who know him. And then I was enjoying that work so much when the contract was up, Kay Teschke and Mike Brower approached me about working on another project. And I said, sure, I'd like to stick around here a little bit longer. And then while we were in the midst of that other project, Mike Brower approached me again and said, would you consider going back to school for a graduate degree? And I laughed at him. And I remember this very clearly because I hated my undergraduate degree and I was never going back to school. But then, I continued in the work, and I continued to understand the public health impacts of the environment, and eventually I did go back to school, and under the supervision of Mike and Susan, got my PhD in environmental epidemiology, and now I am where I am. So to say that the OEH program has been one of the largest influences in my life would be an understatement, and I owe a real debt of gratitude to so many of our colleagues in the school. And to this day, when I hit that 3rd floor in the building, it still feels like home. I know there's renovations scheduled, and that's great because it's kind of ugly compared with the rest of the building, but it is a home for me in all of this. So thank you to everyone, and thanks to the program. Now to the meat of the matter, which is this heat dome that struck British Columbia in the late June of 2021. If you were here for the heat dome, I'm sure you remember it. If you weren't here, this was one of the biggest temperature anomalies ever measured on the face of the planet. And all across British Columbia, we had temperatures that were fully 15 to 25 degrees hotter than they would normally be at that time of year. And in many cases, 5 degrees hotter than they had ever been before. So it's very hard to understate the degree of anomaly that we experienced. And what you see here in this image from NASA is this was a very BC specific event. There's certainly some impacts in Washington State and Oregon and Alberta, but this heat dome parked itself over our province, and there was literally no part of the province that was not affected by these extremely high temperatures. So my first polling question for you is, if you were in British Columbia during the heat dome, What's the highest temperature that you remember in your home? Hey, looks like oh, somebody's got air conditioning. All right. I'm going to go ahead and end that. We've got enough information here to go forward on. There are lots and lots of answers in this kind of 30 to 40 degree range, and some people remembering temperatures in the 40s. When Vancouver Coastal Health and the city of Vancouver did a survey at the end of the heat dome, the highest reported temperature that we had was 56 degrees. Now, that's a very high temperature, but it's not impossible. Certainly, if you have a certain type of windows and they are facing a certain direction during hot weather, your house can really act as a greenhouse and accumulate temperatures that are much higher indoors than they are outdoors. And we'll talk more about this question of indoor temperatures as we move through here. So I want to walk you through this event, a couple of studies that we've done on the event and what we've done as a province since the event to better prepare for these extreme heat emergencies, because this will not be the last one that we face. Before I get into the next few slides, I need to talk about this concept of excess mortality. There's a pretty steady number of people who die in the province on a day-to-day basis. It's about 110 with a standard deviation of about 20. And you can see that here in these green lines. That makes it relatively easy for us to predict how many people we expect to die over any given period. And then that's what you see with this black line, pretty flat. Then we can take the number of people who actually die, or the observed number of deaths, and compare it with the number of people that we expected to die. And this concept is called excess mortality. And you may have heard quite a bit about excess mortality during the COVID-19 pandemic, because it's one of the ways that we can use to evaluate how well we are doing with ascertaining cases. If we count a certain number of COVID deaths, but there's a lot more deaths than that, actually, it may indicate that we are not ascertaining all cases of COVID. So we had 8 days during this period where the observed mortality was statistically significantly different from the mortality that we would have expected. And those bars are colored in orange and red. And you can see this is the population weighted average temperature over the entire population of the province. Over this 8-day period, the temperatures really start going up around the 23rd of June, noting that this was still a high temperature for this time of year, even before the heat started to accumulate. And they increased to almost a population weighted average of 40 degrees. The next day, we see this biggest impact on excess mortality, and the excess mortality continues as the temperatures return to their baseline, which again is still a pretty high temperature for this region at this time of year. Now, when we look at total excess deaths, it differs somewhat from what the coroner's service has been doing, which is reporting on heat-related deaths. So I just need to give you a bit of background here on the coroner's service and what they do. Any death that is unnatural, sudden and unexpected, unexplained, unattended among children or among people in custody must be reported to the coroners for investigation. Anyone can report a death, and the coroners did send reminders to attending clinicians during the heat dome to report any deaths that they thought might have been caused by the heat. But even so, the coroners do not investigate all deaths in the province, and therefore they cannot ascertain completely whether or not deaths were heat related. So when we look at this period, specifically, or most specifically this week of June 25th, we see that there were a large number of deaths compared with other weeks when this heat was not happening, almost a doubling in mortality. And a high proportion of those deaths were reported to the coroner's service for investigation. Even so, it's only 54% of deaths, meaning that 46% of deaths were not investigated and therefore never had the opportunity to be called heat-related deaths, because you can only call a death a heat-related death if you are a coroner, because it is an accidental cause of death. So we overall estimate 740 excess deaths during this 8-day period from June 25th to July 2nd, and that's a little bit discordant from the number of heat-related deaths that the coroners have reported on. Now, I just want to look at this question by age, because there are some important differences here. First of all, not a big impact in people less than 50 years old. We see, slightly elevated deaths on this one day. When we move to 50 to 64 years, we see a different pattern. And in this age group, there was almost 100% increase in mortality. When we move to 65 to 74, we see a slightly different pattern again. And in this age group, there was almost a 100% increase in mortality. This is the next age group. Once again, almost a 100% increase in mortality. And the oldest age group, once again, almost a 100% increase in mortality. So when we talk about these excess deaths in absolute terms, the highest number of excess deaths was in the 85 plus age range, but that's because on any given day, the highest number of deaths is in the 85 plus age range. It's important to understand that we saw a uniform increase in relative excess mortality across all ages over 50. So this is not just a concern for the most elderly people, and that's often a misconception when we're talking about extreme heat. This is a concern for the entire adult population. Before I get into the first study, I just want to talk about some methodological issues about assigning the setting of death. We have two different ways to do this, and usually I don't dig into these weeds in these presentations, but because I know this is largely a student audience, I want you to have a clear idea of some of the underlying decisions when we do these data analyses. So in the first method, we link the 6-digit postal code of the death to known healthcare facilities. That means we know a hospital has a certain postal code. We attach everybody who died at that postal code to that hospital. We have a long-term care facility that has a certain postal code. We attach everyone who died at that postal code to that long-term care facility. And then if we can't make a match between the postal code and an existing facility, we assume that the death happened in the community. The advantage of doing this is that we have those data immediately. As soon as the death is registered, we know the postal code of death, and it's pretty accurate. It's not 100% accurate. The disadvantages of this are that we can't do anything good with deaths at rural postal codes, because the postal code serves the whole community. Everybody has the same postal code, no matter where they are. It's really not very specific. So in some cases, a residence might be at the same postal code as a long-term care facility, and we can't differentiate between those two. Or acute care facility and a long-term care facility may share a postal code, and we can't differentiate between those two. And then we do know some facilities are missing from the database, but we've done a lot of work to fill those in. The second method is using the location of death field in the vital statistics data. So eventually this field will get populated months after the death is registered. Generally, it offers more granularity about where people died, covers urban and rural deaths. The downside again is we have this long data delay, and then quite a lot of this information is missing in the end. So everything I tell you about now, I'm going to be talking about method 1 because that is our preferred method despite its limitations. Now, when we look at these excess deaths by setting of death, we do see a small increase in acute care, and this could be inpatient deaths or emergency room deaths. They would both show up the same way. It's about a 25% increase over what is normal. When we look at residential care or long-term care facilities, we again see a bit of an increase. Again, this is about a 25, closer to 30% increase in this setting of death. When we look at the community deaths, this is where the real story is. There were hundreds of people who died in their homes during this event. And that's perfectly consistent with what the coroners have said. So again, they're going through a somewhat different process, but in the 526 heat-related deaths in that hottest week from June the 25th to July 1st, they have said 506 of those deaths were inside a private residence, some were outdoors, some were in public buildings. But really, this was an episode where a lot of people died in their homes. So why do people die in their homes when it gets hot? This is something that has been recorded and reported elsewhere, and what it comes down to is the indoor temperatures. That's why I asked you about what indoor temperatures you remember during the heat dome. People do not die because it's hot outside for the most part. They die because it is hot inside. Indoor overheating is going to be one of the greatest challenges that we have to face in the changing climate in Canada. These are data from Abbotsford International Airport. The black line is the outdoor temperatures in Abbotsford. The blue line is a home with central air conditioning, and the red line is a home without air conditioning. A couple of key features here. First of all, doesn't matter what the temperature is outside, that home with air conditioning is maintaining a nice, steady, safe indoor temperature throughout the heat dome. The home without air conditioning starts at a higher temperature before it hits the heat dome. That's not surprising. And then day over day, as these outdoor temperatures step up, these indoor temperatures also step up. But note that these indoor peaks are happening a few hours after these outdoor peaks. This is going to be around 5 or 6 p.m. this time of year. These are happening around 9 or 10 p.m. So just when people are starting to think about going to bed. And one key feature of this event was that it was just after the solstice. So we are talking peak daylight hours for all of British Columbia. Now, overnight, even, here on this very hot day, the overnight temperature drops down to about 23 degrees. This is an exceptionally hot overnight temperature for our region, but it is a safe temperature from a human health perspective. On the other hand, this indoor environment drops down from about 38 degrees to about 33 degrees, and then it starts to climb up again the next day. Again, there often seems to be the misconception that the indoor environment will normalize to the outdoor environment overnight. That absolutely does not happen. Homes accumulate heat. I have drawn 2 different polygons on here. One is yellow and it ranges from 26 degrees to 31 degrees. And really where we're going with the evidence and what we're seeing in the evidence is that indoor temperatures under 26 degrees are generally safe for everyone. There starts to be increased risk for those who are susceptible to hot weather when we hit 26 to 31. And then when we're over 31 degrees, we're talking about indoor temperatures that are dangerous for susceptible people. And you can see that this home here spent kind of 4 days during the heat dome in danger territory. Question number 2, what community-related risk factors put people at highest risk of death during an extreme heat event? Well, we're strongly in favor of all of the above here, and I'll talk to you about our next study and hope that you come out with a clearer answer on the other side. So the first piece of research we did around this event was to look at neighborhood factors associated with community deaths in the Lower Mainland. So those are the people who didn't die in hospital and they didn't die in long-term care facilities. And for this assessment, we used vital statistics data. We used data from CANU, or the Canadian Urban Environmental Health Research Consortium, for information about surrounding factors. We made the linkage between these data sets by the 6-digit postal code. And in terms of data governance, all of this analysis was conducted in the BC CDC Central Data Repository, which is our secured data repository at the center. Now, what we're doing here is comparing deaths that occurred during the heat dome with deaths that occurred at the same time of year in other years. And we're only looking at deaths that occurred in the community. Nobody who died in a hospital or long-term care facility is included here. So we had 434 deaths in the Lower Mainland in the community during this 8-day period this is a 5-day period of the heat dome. Our comparator group is deaths around the same time of year. We had to expand out the dates a little bit to get enough people here, and also people who died in the community. We're only looking at adults over the age of 50. And in the heat dome group, we're looking at all underlying causes of death, because at the time we did this, we had really very little information on specific causes of death. In the typical weather group, we are pulling out any deaths known to be due to overdose or still under investigation by the coroner. So that's kind of the data structure for this analysis. And when we compare the heat dome deaths to the typical weather comparators by local health area, this is what we show. So this is just the number of heat dome deaths in a local health area divided by the number of typical weather deaths. And this area of New Westminster really pops out. There were a large number of community deaths also in the downtown east side, but because we're comparing with community deaths at other times of year, this doesn't pop out as much because there's always a high number of community deaths in this region. But overall, we see this, pretty strong impact through East Vancouver, Burnaby, New Westminster, and then somewhat out into the valley, sort of a lesser impact in the coastal areas, which were somewhat cooler during this period. Now, New Westminster, if you're not familiar with the region, this is on the south-facing slope of the Fraser River. So A, it just gets a ton of sunshine during the day. B, there is still a lot of older, lower quality housing stock in this region, lots of low-rise buildings built in sort of the 60s and 70s, and then a lot of those buildings will still only have single-pane windows. There's nothing that accumulates heat more than a single-pane window. That's why we build greenhouses out of them. And because these are lower quality buildings, the rents are cheaper. So we have a aggregation of people who might be particularly sensitive to the very hot indoor environments that they're going to be experiencing. We looked at, first of all, the combined material and social deprivation index as an indicator of deprivation. And we looked at several features of the built environment. When we look at the heat dome deaths compared with the typical weather deaths here, we can see among the materially and socially privileged, there is quite an imbalance. Remains an imbalance in the group that is kind of average deprivation. When we look at materially privileged but socially deprived, things balance out a bit more. Materially deprived but socially privileged, things balance out a bit more. And then we see this real unbalance again in materially and socially deprived areas. And there are some missing data here. These are data that come from the dissemination area level of the census. So if there wasn't enough information in the dissemination area to create the values, the data will be missing. And when we map this out among all of the study subjects, the heat dome deaths and the typical weather deaths, this is how things look. Those red dots are the materially and socially deprived areas, and then the green dots are the materially and socially privileged areas. So you do see kind of these clear spatial patterns in where these more deprived areas are. And then in terms of the built environment variables, we looked at a large number, but eventually widowed it down to these 4. So tree canopy within 100 meters, building footprint within 1 kilometer, distance to major road, and distance from a large body of water. And in all cases, we see that the heat dome deaths are more consistent with this urban heat island effect. There's less tree canopy, there's more building density, there is closer distance to major road, there is further distance from the cooling effects of water. When we combine all of that into one analysis, these are the odds ratios from the logistic regression models. First of all, we don't see an effect of the materially and socially privileged areas. That's null. When we look at materially privileged and socially deprived areas, we do see about a 50% increase in this odds ratio. It's not statistically significant, but it's marginal. When we look at the materially deprived and socially privileged areas, we do see a statistically significant increase, but really where we see the biggest increase is in those areas that are both materially and socially deprived. And when I say materially deprived, I mean those areas are low income, they have higher unemployment rates, those kinds of indicators. When I say socially deprived, I mean that there's more people living alone, there's more single parent families, those types of indicators. When we combine the deprivation index with the environmental variables, the only environmental variable that remains statistically significant in the model is tree canopy, where we saw a 5% increase in the tree canopy was associated with about a 10% decrease in the odds ratio here. So that, you know, these results are pretty consistent with what we would expect. But clear indication of the fact that these deaths are not geospatially uniformly distributed. And this is just another way of looking at that. This is just a heat map of where people died in the community during this event. And again, as I pointed out earlier, there were a large number of deaths in the community during the heat, or in the downtown east side during the heat dome, but because there's often a large number of community deaths in that area, it didn't pop out in the same way on the other map. But I will really kind of draw to your attention here this Kingsway corridor. And when you look at these deaths on a map, which I can't show you, they are just scattered along that corridor all the way down. So question number 3, what chronic condition puts people at highest risk of death during an extreme heat event? All right, good, thank you. So we had heart disease in number 1 position, mental illness number 2, asthma, diabetes kind of tied, and then substance dependency. Well, I hope that the results of our next study will help to clarify some of this for you. Now, this is a different study. This is looking at all deaths during the heat dome across the province, and it's a case-only study of comorbidities associated with potentially heat-related and non-heat-related deaths. The data sources here are vital statistics once again, but now we are linking the vital statistics data by an individual identifier to 26 different chronic disease registries for the province, and I've actually left the health matrix out of this. When I say chronic disease registry, what I mean is an administrative registry of chronic diseases. So if you get diagnosed with cancer, you go into a cancer registry because your clinician puts you there. These administrative registries are not based on a clinical diagnosis. They are based on how people use the healthcare system. So you say, okay, you use the healthcare system like someone who might have asthma, so we're putting you in the asthma registry. So it's a slightly different concept, but these registries often have been well validated against other clinical indicators. And in this case, the data analysis is not happening on the secure data platform at the BC CDC. It's happening on the PHSA linked analytics platform called Panda. So if you work in POP Data BC as a student with your data, Panda is sort of the healthcare equivalent of that mechanism. Now, very similar kind of study design here. Once again, we're comparing deaths during the heat dome with deaths that happened at the same time of year in previous years. The deaths during the heat dome have been split into potentially heat-related deaths and non-heat related deaths. So by the time we get to this study, we have some information on cause of death. And we know that a death has either been identified as heat-related or it's still under investigation by the coroners and they have not yet submitted a certificate of death to vital statistics. Those are those 680 deaths. In the end, not all of them will be heat-related, most of them will be. And then the non-heat related deaths means that the death has received an ICD code that has nothing to do with heat. This time we're looking at June 25th to July 2nd during the heat period, and we're able to look at exactly the same time period in the 9 previous years. And we're only looking at adults over 18 in this case. And in the comparison group, we are including all underlying causes of death. This is sort of a complex chart, just summarizing what I just told you, and that's really this question of the coroner's investigation. So we know that they investigated 818 deaths during the heat dome. We know that in the end, based on their reports, 561 of those deaths will be heat related, but we cannot yet use the data to tell the two apart. So we have 680 deaths in this group. This group, we have 934 deaths. We know those aren't heat related. And here we've got 6,500 deaths in previous years. And I'll talk a little bit more about this complexity on the left-hand side in the sensitivity analyses. When we run models that are adjusted for age, sex, and all other comorbidities, this is what we find. Among the potentially heat-related deaths, there is a very strong effect of schizophrenia. We're talking almost an odds ratio of 3.0 here. Even among the non-heat related deaths, we still see this strong and statistically significant effect of schizophrenia. Now remember, this has already been adjusted for any co-occurring depression or substance use disorder or any of those things. This effect estimate is adjusted for all of these other conditions. We also see depression. Substance use disorder is not statistically significant, but it's certainly elevated. Diabetes is not statistically significant, but it's certainly elevated. And then we go down the line until we see this strong effect in the other direction of dementia. I'll talk about that a bit more in a second. Among the non-heat related deaths, again, we have this strong effect of schizophrenia. We don't see the depression. We don't see the substance use disorder. We see a very similar estimate for diabetes, and we also see a statistically significant estimate for asthma. Now, during the heat dome, there was also several days of air quality advisory due to ground level ozone. So air quality is also very poor. Heat in and of itself would be, independently affect people with respiratory conditions, but when we add the poor air quality on it, it's just another facet of this kind of climatic disaster. And again, in this group, we see this strong effect in the other direction of dementia. Now, what we hypothesize here is that people take care of people with dementia. So they know it's very hot, they may get extra care, and that care may bring them through an event like this in such a way that when we compare deaths during the event to deaths at other times of year, we don't see that dementia has an effect. Now, once again, I just have to stress we're comparing people who died with people who were already dead. So this is not a true case control design. To do that, we need to compare people who died with people who survived, and we're in the process of doing that now. I'm not presenting those results today, but I will happily tell you, not happily, I will, from a very strong public health voice, tell you that the biggest effect in those analyses is also schizophrenia. Now, we did some sensitivity analysis. We know we have a bunch of non-heat dome deaths in the or non-heat related deaths in the potentially heat related group. So we 10,000 times removed a random 118 deaths from those group and reran the analyses to see where the odds ratios came out. And this compares the point estimate odds ratio from the primary analysis to the range of odds ratios observed in those sensitivity analyses. And what you really see here is that they overlap very, very well. So we don't feel that the results have been strongly biased by our inclusion of these non-heat related deaths in the heat related group. Now, just to talk a little bit about this schizophrenia question. If I were in front of you in the classroom, I would ask you to raise your hands if you know someone with schizophrenia, but maybe we can do that on Zoom as well. I can't really see the classroom very well, but can people raise their hands digitally? Yeah, lots of people are raising their hands digitally. So if you know anyone, if you have a close personal relationship with anybody who has schizophrenia, you know what a complicated condition it is. And, there's many, many different reasons why people with schizophrenia may be at risk during these events. So, the condition is characterized by disorganized thinking, a lack of insight or anosognosia into one's own health. So it's very possible that people with this condition simply do not recognize the threat of heat in the same way that people without this condition might do. And then in addition to that, schizophrenia co-occurs with substance use disorder in many cases, which is in and of itself an independent risk factor. It also is highly associated with lower socioeconomic status and highly associated with lower social connection. So social isolation also contributes to this. And then finally, there's the question of the pharmaceuticals often used to treat schizophrenia. Some are well known to interfere with thermoregulation. So it's a very complex picture that we have here. And we did some work to help the BC Schizophrenia Society really communicate about those risks with the people they serve. And if you're not familiar with this society, they serve really families and support networks of people with schizophrenia. So what we found in these preliminary analyses, and we'll do a lot more work on this, was that a higher proportion of the people with schizophrenia who died compared with the whole BC population with schizophrenia was on antipsychotic medication a higher proportion of them was on the types of antipsychotic medication that would generally be used to treat quite severe disease. And overall they had more drugs prescribed than other people with schizophrenia. So these might be indicators of more severe disease. They could also be indicators of people who simply live with schizophrenia for more time. Overall, we really need to speak carefully about this, because there is a tendency for people to go straight to the pharmaceuticals. Well, it's the pharmaceuticals that put people at risk, without thinking about all of those other facets of the condition and the social environment of the condition. And we do not want people to stop taking their medications during extreme heat events. That's not a useful way forward. There's no clinical evidence to suggest that that's how people should behave. So I think you'll see quite a bit more about this in the years to come. This is kind of wrapping up now. So the themes that we have in terms of risk factors and protective factors: indoor heat is the #1 risk factor. Air conditioning is the #1 protective factor. There's no doubt in my mind, even though we haven't directly we haven't directly analyzed those conditions. Mental illness, obviously, both schizophrenia and depression showing up here. Social isolation, substance use, deprivation, diabetes, asthma in some cases. Protective factors are indoor, a safe indoor environment, privilege, surrounding green space, social connection, being cared for. And then in all of our analyses, angina shows up as being protective. So it's possible that there is something about the medications used to treat angina that is somehow helping to protect people during these extreme hot weather events, because we found that in the case only analyses and the case control analyses. This is not a problem that is easy to solve. To do better next time, and really I want us to do better next time, we need action at a wide range of levels. We need individuals and families to plan around extreme heat in the same kind of ways that they would plan around wildfires or they would plan around earthquakes. People need to understand that these are extreme events with risks, and that pre-planning can help build resiliency. Communities and municipalities certainly have a role to play. And then, but what are the provincial and national policies that are going to help us do better next time, both in BC and across Canada? So one of the things that we got done between last year and this year was the development of the Extreme Heat Preparedness Guide. Again, these are the types of guides that you would see for wildfires or earthquakes. And this just helps people walk through some planning processes for themselves and their families, identify who's at risk, and then question number 2, can you stay at home? Can you be safe at home? If you can't be safe at home, start thinking about what the other options are. Again, driving down to this question of indoor heat as the thing that kills people. The National Collaborating Center for Environmental Health put together this guide for checking in on people when it's extremely hot. So we know that indoor heat is a problem. We know not everybody's going to magically have a safe indoor environment in the years ahead. That's going to take years and years of policy changes. So one of the best tools that we have available to us now is checking in on people, because if people themselves are incapable or unable to understand the threat of heat, somebody else might have to identify the threat for them. Now, not everybody is fully knowledgeable about the signs of heat-related illness and the symptoms and what to do in case of heat-related illness. Not everyone is fully knowledgeable about what healthy body temperatures are, what healthy indoor temperatures are, when things might be risky. So this is just a 5-page document for a lay audience to walk them through these things and to walk them through how to do an effective check on someone. This was developed in very close collaboration with the Glenn Kenny's group at the University of Ottawa. And then the biggest policy shift that we saw this year, and we will maintain in the years ahead, was moving to a two-tiered alerting system for the province. So prior to the 2021 heat dome, we had a heat warning and nothing else. We need to differentiate between very hot weather that does carry some public health risk and dangerously hot weather that constitutes an emergency. And that's really what we've put in place for the province. You probably, if you were here this summer, you heard there were a lot of heat warnings. God, there were a lot of heat warnings, up to 6 in some areas. One of them lasted for 8 days. It was a hot summer, but we didn't see what we know are the emergency conditions, which is this day over day over day increase in temperatures after we've reached the heat warning thresholds. That's what happened in 2021. That's what happened in 2009. That's what translates to very hot indoor temperatures. If we have an extreme heat emergency in the future, you will get a text on your cell phone the same way you do when there is an Amber Alert. We have arranged things such that we can use this type of broadcast intrusive alerting to tell people there is dangerously hot weather coming. Please get ready. And then, on the really boring side of this, there's a very long document with a lot of tables in it outlining what the roles and responsibilities are for different groups. What should public health be doing under a heat warning, under an extreme heat emergency? What should municipalities be doing? What should BCEHS be doing? And this, although it's kind of boring and administrative, this is how the BC heat alert and response system was built. This is the kinds of stuff that we need behind the scenes so that when we're faced with these conditions, there's a booklet and people can grab the booklet and say, okay, have we done these things that we said that we would do? And then finally, this question of indoor temperatures, I've referenced a couple of times, we're going to need a lot of policy change to change this in Canada. I mean, first, we got to look at the building code so that we're not building buildings anymore that can get so hot that people die in them. That's what we should be done with that now. But then, a typical building in Canada is going to have a lifetime of 60 to 80 years. How are we retrofitting the existing building stock to ensure that it stays safe in the climate future that we're going to be facing? I'm sitting on a couple of committees right now to talk about setting indoor temperature standards for Canada and more globally. Regardless, one of the best things that we can do in the short term is encourage people to monitor their indoor temperatures. If you have someone in your life who may be sensitive to extreme heat, give them a digital thermometer when it gets hot out and say, every time you call, hey, grandma, what's it say on your thermometer right now? Because that's going to give you a lot of powerful information about the risk. And then, from our perspective at the BCCDC, we got a lot more research to do. We've got this true case control study of mortality underway, sort of all mortality. We have a similar study underway for those who died with schizophrenia. More work into the risk and protective factors that may be associated with some pharmaceuticals so that we can better inform pharmacists and they can better communicate with people who are receiving these types of drugs. We'd like to look more into these protective effects of green space. It's very low-hanging fruit from a community perspective in terms of how to confer a large amount of benefit to a large amount of people, and further work on the question of indoor and outdoor temperatures. One of the complications here is it is not directly proportional. We can't take an outdoor temperature and forecast what it's going to be inside. It is so building dependent. So really trying to build a better understanding of what the range of possible is under different outdoor scenarios. And the final question, will this presentation change how you and your family approach extreme hot weather events? Okay. Well, for those who said no, I hope you were already quite knowledgeable about all of this and that you have air conditioning. But really what I wanted out of today is just to highlight, there's a lot of intuition around what happens during extreme hot weather, but I just wanted to highlight some of the evidence that we now have available in the province about this event, and allow you to kind of stack it up against your intuition, and thinking about who's at risk. Because once again, this will not be the last time this happens. Thank you.